Thank you. It is a pleasure for me to be here this afternoon and to discuss with you some important aspects of depression and hypothyroidism, and that will be the platform for showing you the right way to treat patients with hypothyroidism with combination of T4, T3. Over 20 years ago, I used to prescribe L-thyroxine only to my hypothyroid patients because that's what I was taught to do. And I realized very quickly that most of them, the majority of them, continue to complain of lingering symptoms of low-grade depression, anxiety, cognitive symptoms, and fatigue. At the same time, when I saw a patient who was taking Armour thyroid, I tried to switch that patient from Armour to L-thyroxine, obviously. And I was facing many unhappy patients, and I didn't understand what I was doing. But that prompted me really to do a lot of thinking about this matter, and having been trained by one of the discoverers of T3 back in 51, 52, I realized that there was a role for T3 in the management of patients with hypothyroidism. So I put together protocols, etc. Coincidentally, the publication of the first edition of the thyroid solution in '99 coincided with the first peer-reviewed paper on T4, T3 by Benevicius, which showed some mental benefit when patients received T4 plus T3 versus T4. The study was really not very well done. Since then, there were 11 studies that were published. Some of them did not show any benefit, and that's what introduced this controversy in the traditional medicine. And the current teaching now is that T4, T3 in traditional medicine, T4, T3 is not really helpful. But in fact, when used appropriately, T4, T3 therapy should be the future in the treatment of hypothyroidism. I'm going to review very briefly how the thyroid system works. The thyroid gland produces two thyroid hormones, T4 and T3. As you see, on a daily basis, approximately 6 to 8 micrograms of T3 are produced by the gland. All the T4 is produced by the thyroid gland, 80-90 micrograms. And 80% of the T3 derives from the conversion via the 5' deiodinase from T4 to T3, and that will provide the system with about 20 to 24 micrograms of T3 on a daily basis. So as you see, if the gland is not working properly, there will be a deficit in T3. If in addition the T4 to T3 conversion in the system is not perfect, then there will be an additional tissue hypothyroidism in our hypothyroid patients. And you are all familiar with the feedback mechanism whereby the thyroid hormone affects the TSH secretion, and that's why TSH continues to be the standard diagnostic test for hypothyroidism. Now, you can get hypothyroidism as a result of a hypothalamic or pituitary problem, such as a tumor or hypophysitis, for example, an autoimmune attack on the pituitary gland, which is actually increasingly recognized as a co-occurrence with Hashimoto's thyroiditis. So it's not uncommon to see a patient with primary hypothyroidism having a combination of the two deficits as a result of the pituitary and the thyroid at the same time. If the gland is the problem, that's primary thyroid failure. The most common condition is Hashimoto's thyroiditis, which is an autoimmune disorder. It's the most common cause of hypothyroidism. Then Graves' disease after treatment, whether it's medication, surgery, or radioactive iodine. And then you have subacute, silent, postpartum thyroiditis. So a significant percentage of these occurrences will lead to some deficit of thyroid hormone in the long run, and that can make the patient suffer. Radiation to the head and neck, and many other rarer situations related to lithium, medications, iodine, surplus of iodine or lack of iodine, and enzymatic defects, etc. And then we have the tissue hypothyroidism, thyroid hormone resistance related to either a defect in the deiodinase that converts T4 to T3. It could be a receptor problem or a post-receptor problem.